I say more. Okay, so basically, let's start with nausea and vomiting. As you all know, nausea vomiting is a very distressing and a common symptom, and seen in patients with cancers and other life-limiting illnesses. Principally, it's a behavioral adaptive mechanism to avoid ingestion of toxin. It's like a natural way of telling, okay, we don't want any toxins taken to our body, so we are just putting it out. It's like diarrhea, putting infections out. So it's kind of a actually good thing to a certain extent, but just that it's sometimes difficult to cope with. In palliative care patients, we try, like in every condition, try to find why they have that symptom, why they are vomiting, why they are having nausea. But a lot of times it's quite difficult to find exactly why people have that symptom. And even if we do find a cause, it's usually multiple. So we need to kind of, I'll talk about that later. We need to kind of target multiple pathways to help patients' symptoms. One of the common symptoms that get mixed up with nausea and vomiting in patients is regurgitation. So regurgitation means it's basically a passive thing. So vomiting is basically they get that retching feeling and they whereas regurgitation is a passive thing. Just put the things out. There is no that initial. It's not very good. Okay. Right. So basically, it's important to differentiate that symptom because the treatment is going to be different. Regurgitation typically occurs with reflux, so gastroesophageal reflux, and also and symptoms like people who have obstruction in the esophagus. Okay. So that I'll come to that later. And when we talk about the nausea vomiting, we always try to categorize into different syndromes. You can use this basically in a general practice as normal patients, or you can use it particularly for palliative care patients also, because it kind of gives us a pattern recognition of patient symptoms, and also helps us to target what treatment should be best for that patient. Okay, so we have what we call clinical toxicity, gastric outer obstruction, esophageal diseases, bowel obstruction, cranial diseases or treatment, movement disorders, or there are obviously things which are unclear or have multiple causes. So basically, first thing, if any patient comes, we need to assess that patient. So we need to find out, okay, is this nausea, vomiting, is this retching, is it regurgitation? Try to differentiate what exactly that symptom is. In medicine, as you know, sometimes very difficult to do that. But you at least try to see, because the treatment is going to be very difficult. Because I've seen patients who have esophageal diseases, people keep on giving antiemetics, but that doesn't help because it's nothing to do with the vomiting. It's just basically patient is not putting things down through the esophagus. They're just putting it out. So giving antiemetics for those patients is useless. So that kind of differentiation should be made. Try to find the etiology. See whether you can find whether it's an obstructive problem or is it a esophageal problem. I'll show you the symptoms which will help do that. Try to find the etiology because treatment is again going to be different. See how it affects the patient, how bad it is. People say they are vomiting, but see how much it affects them, how frequently it happens during the day, and how much it affects their quality of life. And then try to see what the consequences of this are. Do they have weight loss? Do they have fatigue? Are they dehydrated? Do they have electrolyte imbalances? Does it affect other drug interactions? So patient might be vomiting, might be dehydrated, so patient can't take other drugs, or dehydration is affecting the other drug. Hypokalemia is affecting other drugs. So will it cause drug interactions? And lastly, you need to obviously, like Dr. Abhinay said, speak to the family and see how it affects the family, okay, and the carers. So, like I told you, try to identify the clinical syndrome. In your examination, see whether the patient dehydrated, sepsis, and the evidence of other drug toxicity features, evidence of increased intracranial pressure, abdominal symptoms. Just palpate the abdomen and see whether there is any abdominal organomegaly. How the bowel sounds, are they increased, are they diminished? The suction flash to see whether the stomach is obstructed. And it's a good thing if you can do a DRE, see whether there are stools in the rectum. It's patients who have vomiting, the problem might be actually in the rectum, not actually in the stomach or the esophagus. They might be just having chronic constipation. And if you just put enema and relieve that constipation, that whole the vomiting, all the cycle will be removed. So a DR is also very useful in vomiting patients. A few investigations you can do. You can do blood urea electrolytes, you can do liver profile, calcium, blood sugars, UFR to see whether the infections, CRP. So few things. Now you don't need to do a gamut of investigations, but few things. X-ray might be useful to see whether if you're suspecting bowel obstruction, and endoscopy might be indicated depending. These are basically if you're thinking there is some sort of obstruction in the for the patient's symptoms. So few basic blood investigations, and then you go for the next line, more higher, more high-end investigations. So when you talk about management, you try to find the cause, manage it. Okay. Again, I'll go to that bit later. I'll go more specific. So if the patient is having hypercalcemia, I try to treat the hypercalcemia. If the patient is having constipation, I treat constipation. And there are certain non-pharmacological managements you can try them first. And try to find the antiemetic which is likely to treat that particular cause, or you might have to use a combination of antibiotics, and try using combination of antiemetics like prokinetics and anticholinergics, because they kind of antagonize each other, because their pathways come to a particular point and they kind of antagonize each other. So things like cyclisine and metoclopramide or domperidone and things cannot be combined together. Then you need to consider how you're going to give it. Whether you're going to give it orally, are the patients able to tolerate it orally, or whether there are you give it sublingually or buccal preparations available in Sri Lanka, or whether you need to give it parenterally. So you need to have an idea how you want to give it, or you might be able to give it rectally in Sri Lanka, because rectal preparations are commonly used. Sublingual preparations are available in Sri Lanka, but so in the private sector, you can see whether you can use them when you're giving the drugs. Non-pharmacological management, they say always look at the mouth, see whether the oral hygiene is good, because bad oral hygiene itself can cause nausea, vomiting. And like I told you, see about the bowel habits. Any patient come with vomiting, ask them, are they constipated? If they are constipated, you need to relieve that obstruction down there. Otherwise, it will not get better. So ask a question about the bowel habits and try to correct it. Ask them to eat regular, small, palatable portions rather than having large, big meals. So 6 small meals rather than 3 big meals, and avoid strong smells. So fatty, spicy, highly salted food might be. Patients say that they trigger nausea, vomiting, might have to stop them or reduce them. If the patient is agitated, anxious, a calm, reassuring environment might be useful. And some people say ginger is useful, but that's something that you can suggest and see whether. So for few things about non-pharmacological management. When you look at pharmacological management, there are 2 approaches you can use. Like I told you, you can think of the particular cause and think of what you call these emetic pathways. Emetic pathways are basically, you would have kind of heard about these. You get the different vomiting center, the cerebral cortex, the vestibular nucleus, the gastrointestinal tract, chemoreceptor triggers also. You can try to figure out where each problem is affecting. If the patient is anxious, it might be affecting the cerebral cortex. If the patient's vomiting is due to increased renal intracranial pressure, it might be a pressure receptors. If the patient is having obstructive symptoms, it might be GI related. So in the GI tract, the problem might be. Chemoreceptor trigger zones are due to toxicity. So if you can actually, or vestibular nucleus might be due to movement problems. So if you can kind of try to find out where the pathology is originating from, you can particularly treat that particular point. But the problem, like I told you, is it's very difficult to sometimes identify them. And also it's multifactorial. Somebody might be vomiting because of a GI problem plus a chemoreceptor trigger zone problem. So sometimes it's not easy to find that particular etiology and treat it, although we try to do it. Okay. Things like motion sickness, we treat with a particular drug, because we know motion sickness does not respond to other drugs, and it responds to a particular drug better. So by experience, we kind of know those things. So that is what we mean by this mechanistic approach. Other thing is empirical approach, where any patient come with vomiting, we give domperidone, we give metoclopramide. So we always try with anti-dopaminergic drugs. First thing, if the patient comes to our GP practice vomiting, first thing that we do is give antiemetic. Okay, either commonly we give is uh, domperidone, or some people give ondansetron. So it's a general approach. You don't think about what the cause is. You basically just give a empirical drug. Or then if that doesn't work, you give a combination. You give ondansetron plus domperidone. So you can give a combination. And then of course, if that doesn't work, you need to think about refractory medicines. So you can use both approaches. Sometimes one works better than other, and sometimes you need to. Anyway, it's good to always use the mechanistic approach, because that is likely to be much more successful at the end. So these are some drugs which we commonly use. On the left-hand column is the drugs which we use commonly for vomiting and nausea, and these are the receptors which they work in. I don't think you need to remember, but it's good to just have a rough idea what are the different drugs which are available for. I'll maybe give this as a handout to you all later, so you don't need to actually copy it or take photographs. You can just have a look at it later and try to see whether you can kind of remember some of the drugs, some of the common things you will remember anyway. So coming back to those nausea vomiting syndromes, let's take one by one. Okay, so the clinical toxicity. Clinical toxicity is commonly due to, if you look at palliative care patients with cancer, is due to carcinomatosis. So cancer spread everywhere. Or if you're looking at an infection, where it's a florid infection, it's due to chronic inflammation. Or it can be due to metabolic causes like hypercalcemia, biochemical upset like uremia, or drugs like chemotherapy, or very strong antibiotics. They basically have clinical toxicity symptoms, and they basically affect the chemoreceptor trigger zone. And those patients will have symptoms of continuous nausea. They'll always be nauseous. Their nausea does not get better because the toxicity does not get better. And if the patient is uremic, it doesn't get better until you dialyze the patient. So they will be always, it's a persistent symptom. It doesn't get better with anything. Okay. And it gets aggravated by sight of food and smell of food. Okay. And is not relieved by vomiting, typically. Okay. So that is basically toxicity features of vomiting. And if you suspect that to be the cause, they have found that these haloperidol, chlorpheniramine, ondansetron, or levofloxacin are the drugs of choice for these kind of symptoms. So, and if you look at this, domperidone does not typically work for this patient. Okay, although it might help this patient, but domperidone is not the drug of choice for these patients. If you think of a patient obstructive symptoms, obstruction may be due to opioids, maybe due to anticoag, maybe it's a drug-related stasis obstruction, or maybe a cancer in the pylorus which is causing obstruction, autonomic failure, or there is a organomegaly which is squashing the stomach and the stomach is unable to empty, maybe peptic ulcer, hypercalcemia. All these things basically cause stomach emptying to be impaired. Those people will basically complain of intermittent nausea. They'll all be early satiety. They feel quickly, because their stomach is obstructed, they feel full quickly. So they'll feel full after eating quickly, and they'll feel bloated. Okay? And the nausea is relieved by vomiting. That is usually small volume. So if they vomit, their nausea gets better. And that food and that vomiters obviously will contain food. Okay? So those sort of patients, the dopamine drugs will be useful. So metoclopramide, domperidone, those are basically prokinetics. Basically stimulates the stomach to move quicker. And they say dexamethasone. And if you're looking at much bit more further, endoscopic, so if you have an obstructed patient in the pylorus, putting a stent into the pylorus might be useful. These are patients who are probably not surgically amenable, not surgically fit. So endoscopic approaches might be useful. Okay, so these are patients who have obstruction in the stomach. Second are patients who have esophageal problems. So esophageal problems, like I told you, can be due to tumors, toxins, inflammation, say maybe candida, infection in the esophagus, or maybe a blocked stent even. So patient might be esophageal cancer and having a stent, it can be blocked. So they will have that regurgitation symptom, not vomiting. They will just passively put out everything. And they might have dysphagia also. And those patients, the drugs of choice would be H2 receptor blockers like ranitidine, endoscopic stenting, consider, you can use dexamethasone if you're suspecting infections, antifungals, antivirals, antibiotics. Antiemetics are often very ineffective in these patients. So that's why the importance of being able to recognize this particular syndrome in these patients, right? Bowel obstruction is a bit more down. So more in the small intestines or large intestine. It may be in carcinoma in the abdomen, again maybe hypokalemia, maybe constipation, maybe autonomic problems. They have intermittent nausea, but they have abdominal cramps, especially if it's due to obstruction. If it's due to paralytic ileus, they won't have cramps. It will be a non-obstructive, like a gaseous distillation of the abdomen. Okay, and their nausea is again relieved by vomiting. And they say that bowel, so with small bowel or large bowel, with vomiting occurs in small bowel, it's more large volume, and it's, as you all know, it's bile stain or fucular. Okay, so in stomach content, it might be small volume. In its stomach obstruction, if it's small volume, small bowel obstruction, it might be large volume vomiters, which is relieved by the patient's nausea is relieved by vomiting. Okay. Obviously, if the patient has obstruction symptoms, first treatment is surgery. But if the patient is not fit for surgery, then you have to think about medical management. If you basically, if you're thinking of obstruction, it's painless, okay, then it's likely due to peristaltic failure. So that means like a paralytic ileus. So those patients, you need to stimulate the bowel by giving metoclopramide or domperidone. But if the patient is having painful obstruction, that is due to some sort of mechanical obstruction. Okay, if you can't relieve that obstruction by doing surgery, then you need to give symptomatic treatment to relieve the patient's symptoms. So for the colics, you give hyoscine, you can give levofloxacin or cyclisine haloperidol combination, or obviously you might have to put an NG tube. Okay, or even peg tubes. You can give peg tubes. You can what you call venting peg tubes. So patient is able to take some water to mouth, but to the peg tube, you remove it. So there are different therapies you can use for these sort of patients also. Okay, so those are for bowel obstruction. If you're thinking cranial diseases, okay, things like intracranial pressure due to metastasis, radiotherapy, or brainstem diseases. So obviously those patients have evidence of increased intracranial pressure. Might be early morning nausea, vomiting, headache. They might have cranial signs. Their consciousness might be impaired. Okay, so those sort of people, if they have nausea, vomiting, the drugs of choice will be cyclisine and dexamethasone to reduce the inflammation and also reduce the pressure in the brain. Okay, so again, finding the cause is very important. So these are patients, giving domperidone is not going to be useful. Movement-related problems like vestibular diseases, base of skull tumors, motion sickness, those people's nausea and vomiting is aggravated by movement. Okay, including motion sickness. Even just turning the head will induce vertigo or dizziness. Okay, and they have vertigo dizziness associated with nausea. Okay, these are patients, the drugs of choice will be cyclisine, cinnarizine, levofloxacin, or chlorperazine. Okay, so again, doing a symptom analysis will help target your treatment. If you do your basic assessment, you can't find the cause for nausea, vomiting, then of course you need to go for that empirical approach. Okay, where you're not sure what it is. Then of course you might have to give metoclopramide, or you can give this levofloxacin, or a trial of dexamethasone. Or if you think patients' nausea, vomiting is due to some sort of fear, anxiety, which all our palliative care patients might be, they're worried about dying, they're worried about their family, so lots of things. So those patients, giving benzodiazepine might be useful. You just need to relieve their anxiety, then their nausea, vomiting might get better. Okay, so that is basically a syndromic approach. And so you can basically forget everything I told you. This is the syndromic approach to managing nausea, vomiting in palliative care or even in a general practice. Any questions in this bit before I go to constipation? No. Okay. Right. So if you all have questions, you can ask later. So let's talk a bit about constipation. Constipation means, so basically what we need to find out is first, what do we mean by constipation? Constipation is basically small, hard stools which are infrequently passed. or difficult to pass. Okay, and that is specific for the patient. Okay, for the patient, if open the bowels twice, like every 2 days is normal, that might be normal for him, but it has to be something specific for the patient. Okay, so for you and me, constipation might is a bit of a subjective thing. So any change in movement or change in consistency of bowel habits to becoming harder or patient needs to strain further means the patient is constipated. Okay. So there are two aspects that should be considered when defining constipation palliative care patients. Always look at the symptom, whether it's actually affecting the patient. Okay, such as the frequency and the character of defecation. So sometimes, even though we think the patient is constipated, for the patient it might not be a problem. Okay, so see how bad it's affecting the patient and patient's perception of constipation, which is related to the level of discomfort change. So again, how bad the patient feels the patient's constipation is. So in palliative care, we don't try to achieve 100% goals. We try to keep the patient comfortable. Okay, so it's always good to ask the patient specifically how it affects the patient, and if it doesn't affect the patient too much as psychologically or physically. Obviously, even if the patient is affecting physically, then we need to do something about it. But otherwise, we need to basically speak to the patient and see how much it's affecting the patient, how distressing it is. Um, consequences of constipation, there are lots. You can have anxiety, distress. You can have rectal pain, abdominal pain, distension. Like I told you, nausea, vomiting, anorexia might be just due to constipation. So patient might say, I don't have appetite. But basically, if you ask them that they're constipated, really the constipation, the appetite might improve. So very simple things like that. Urine retention is a common thing due to constipation. Old people become confused. Okay, they can have inadequate absorption of drugs. They can have fecal infection, rectal tearing, rectal fissures, hemorrhoids, bowel obstruction, perforation. So lots of things can occur due to constipation. So you have to be aware of the effects of constipation, because sometimes it might be completely unrelated, like anorexia. You might not think that constipation causes anorexia or loss of appetite, but actually it's a simple association. A simple thing will help relieve the patient's symptoms. Again, how do you do the assessment? Identify the problem and likely causes. I'll go through that later. See what the current pattern of bowel motions are. Is there how frequent is it? The consistency, how difficult the patient is able to pass the stools, whether it's blood, whether it's painful, or whether they have overflow diarrhea. Sometimes constipation patients come with diarrhea. If you actually ask them, they say that they pass little bit of liquid stools very frequently. But actually, if you put a finger into the rectum, you will feel it's completely impacted stools. So that patient, if you had given things like Imodium, it will actually make it worse. That patient actually needs a laxative. So that's very important to do that assessment at the beginning. See whether it's painful, okay, whether it's colicky or a diffuse discomfort. When the patient has evidence of bowel obstruction, if it's absolute constipation, pain, nausea, vomiting, bloating, other patients using laxatives before, or patient has used laxatives before, because if you just prescribe the same laxative, patient not going to take it again, because if the patient has already been on the same laxative, so you try to get the history of what the patient has been already, because a lot of our laxatives are over the counter. So when the patient comes to us, they would have already tried several laxatives. So just writing the same laxative won't help at all. Okay, or you need to at least explain why you're giving it. Do abdominal examination, rectal examination. If the patient has stoma, do a stoma examination. Like I told you, it will help to find what the cause for the constipation is, and see whether complications of constipation are, like UTIs. The causes of constipation, okay, broadly, you can get the pharmacological things like drugs, so drug side effects, anticholinergic drugs, the other common cause of constipation. You can give calcium channel blockers, like the antihypertensives. So diuretics can cause dehydration, hyperkalemia. Iron, again, a very common drug which is used, can cause constipation. Opioid containing, so if palliative care patient might be on opioid, so that can cause constipation. So you have to kind of figure out whether a drug is causing this patient's constipation. Common drugs, not, you don't have to go through all the drugs. Then a few metabolic causes, things like hypokalemia, uremia, hypothyroidism, diabetes. These are very simple things of serum calcium, serum potassium. We do it, you can find out what the cause for the constipation is. And just dehydration. If dehydration that might be causing constipation because the patient is having stools are very hard, very dehydrated, the patient might be in constipation. Neurological problems might be quite obvious, might can cause constipation. Then, of course, the structural problems. Any pelvic problem, radiation, some sort of a anorectal problem, fissures. So all those things can cause constipation. Can be obstruction, can be bowel obstruction, can be causing so it's some sort of a structural problem in the colon can basically cause constipation. So broadly, we divide the cause of constipation with that. But the commonest causes for constipation in most patients are pharmacological agents. So always try to get any patient comes with constipation. First thing I do is look at the drug chart, see whether the patient is on any drug which causes constipation. Just stop the drug, and patient's constipation might get better. Okay, so it's very important to do that. And the metabolic causes. The structural problems are rare. You get it, but it's rare as a cause for constipation. Okay, so you need to think of it at the back of your mind only. What are the functional causes? So dietary things like poor appetite. If the patient is taking low amount of low fiber diet, maybe poor intake. Environment causes like lack of privacy, comfort, or so patient has no proper toileting facilities, so patient is not going to the toilet because of that. Advanced stage, patient is maybe immobile, so he can't go to the toilet, so he's just tightening his stools and waiting. So depression, so maybe patient might be sedated. So there are lots of other reasons patient might be constipated. So always you need to think about other reasons than the organic causes which might be contributing to constipation, especially when you're dealing with palliative care and old age people. Okay. Again, management. Okay. So ensuring privacy and comfort to allow patient defecate normally. A stool to elevate the knees. So this is actually very helpful. So patients have what you call the defecative problem. So the stools basically come into the rectum, but they're unable to put it out the rectum. Okay. So the rectum has a lot of things which need to coordinate for the stools to go out of the rectum. So for those people, so they what you call defecative. They feel that the rectum stools are in the rectum, but they can't put it out from there. Those people having a stool where they can put their feet up might help to change the angles of the rectum. So that's useful. Obviously, taking a lot of water is useful. Increasing activity and mobility in patients are useful. And anticipating constipation side effect of the drug which you're giving. Like obviously, we know opioids cause constipation. So you give laxatives prophylactically. Okay, you give a stimulant laxative prophylactically. And use oral laxatives if possible in preference to alternative routes. Okay. Treatment can be per rectum, may be necessary, alone or in combination with oral laxatives. Okay. In patients who cannot tolerate oral laxatives, you might have to give rectum. Patients who have fecal impact, so the DRE, if you do DRE and if you see lots of stools, giving oral laxatives are not going to be useful. You need to put a rectal laxative. And people who have spinal cord problems, again, nerve problems, again, the stools basically will be coming to the rectum and getting stuck there. Again, those people need rectal laxatives. So you need to be able to find out. So that's a DRE at that point is very useful to know whether oral laxatives or rectal laxatives are useful. When constipation diagnosed, a spontaneous bowel action may not be possible if fecal impaction is present. In these circumstances, the anemia and suppository is needed. Again, when a patient comes with constipation, do a DRE and feel there are stools impacted. Just giving lactulose or clemifene or whatever the drug, I'm using trade name, don't. So basically, just giving a laxative orally is not going to be helpful. You need to put something rectally to clear out the bowel. So it's a long tube. You need to remove that block. If you remove that block, only the rest of the stools will get loose and come out. Okay. So a rectal suppository or some sort of enema is very useful in those patients. Okay. And do not give drugs per rectum if you think the rectum is balloon and empty. So that's why if the rectum is empty, there is no point in giving drugs rectally. Generally, most people will benefit from combination of softeners and stimulants. Okay, I'll touch on that again. Okay, Rather than giving one thing, you combine laxatives, they're actually much more useful. If oral laxatives treatment is given alone, bowel action should be expected within 3 days. If this does not occur, the use of combination of softening and stimulative laxatives is essential. The dose should be titrated upward on a daily or alternative basis until the bowel action occurs. So you need to give some time for the laxative to work. We need to explain to the patient these are drugs which will take some time to work. So stools at the moment are all hardened up inside. So you need to give some time. So don't think you give the drug today, in within 2-3 hours, it's going to all get empty. So they need to explain to the patient this is something which has occurred over a few days. So it will take 1 or 2 days for it to get better also. Okay. The occurrence of colics mean that the dose of softening laxative should be increased relative to the amount of stimulant. So if the patient has constipation with colic abdominal pain, if you give a stimulant laxative, what is going to happen? The colics are going to be worse. So, any constipation patient, first, the pain is very useful. If it's a painful constipation, you need to give softening laxative. Whereas if it's a painless constipation and there is what we call this overflow incontinence, giving softening agents will actually make it worse. You need to give stimulant laxative. So small things like pain can help you differentiate which particular drug you want to give that patient. So pain, digital rectal examination are very useful in assessing a constipation patient. Bulking agents like ispagulas, methylcellulose brand, if taken with inadequate water, can precipitate intestinal obstruction through formation of viscous mass in the bowel. Therefore, should not be routine used in palliative care. Okay, so remember when you're using in palliative care, use these bulking agents. In Sri Lanka, we have what we call fibogel. We have what else? We have another one with I can't remember the name. Anyway, so anything with raw fiber in palliative care is likely not going to be very useful. Okay, so because what I tell patients, the stools will become like cow dung, or not cow dung, like elephant dung. It will be very fibrous, hard, big stools, lumpy stools. So that stools are not going to pass through the colon, especially in an inactive bed-bound patient. So don't use bulking agents in bed-bound, immobile palliative care patients because it's likely bound to make it worse. Unless if you are dead sure, if you are really sure the patient is able to drink a lot of water. Because if you are using these even in normal people, okay, even in normal practice, if you are using bulking agents, fibers, make sure that you tell the patient they need to drink a lot of water. Otherwise, it will make the symptoms worse. Okay, right. So these basically are summary of the laxatives which are being used. Predominantly, so the top ones are predominantly softening agents. The bottom ones are predominantly stimulant. Remember, laxatives are combined actions. Okay, that's when companies make laxative, they make it with a combined preparation. So they have a bit of softening effect, they have a bit of stimulant effect. So usually it's not a single effect that they have, action they have. Okay, so some have more softening effect, some have more peristaltic or stimulating effect. Okay, so the common, most of these things are available in Sri Lanka. Dr. City is not available, but most of these things are available in Sri Lanka. So you need to identify which laxative has which predominant effect, okay, before prescribing to the patient. So again, how do you manage the patient? So like I told you, first line is a combination of a softener and a stimulant, okay. Second line is a rectal suppositor enema. If you're thinking of peripherally, if your patient is on a long-term opioids, you can use peripheral acting opioid antagonists, okay. And if as a third line, you might have to use manual evacuation. In paraplegic patients, you might the stools might be actually hard in the rectum. So you might have to use a combination of laxatives or loperamide, depending on how the stools are. So you might have to do a DRE and see how the stools are. If the stools are liquid and impacted, you might have to give more loperamide. If the stools are hard, you might have to give more laxatives. Okay. So again, these simple things like DRE will kind of give you that information, what kind of drug specifically is useful for these patients. Right. Last two slides. Constipation can be, in a dying patient, constipation can still be a problem in the last few days of life, less apparent as they become comatose. Management of constipation becomes a low priority in overall care. In the last few days of life, when patients are no longer able to receive medication, the level of consciousness diminishes. Oral laxatives should be discontinued. Obviously, try to give oral things less if the patient is unconscious or less conscious. So the need for rectal care is likely to be rare. Also, rectal care is likely to be necessary at this stage. So obviously, dying patients stop giving oral drugs, and you can think less about obviously the GI tract and think about the other things much more important to the patient. Remember to consider the patient as a whole patient rather than just the patient's GI tract or the respiratory tract or whatever. So think of the whole patient. Symptoms are rarely purely a physical or purely a psychological. It's a combination of things. And all symptoms and treatments impact on the patient, their family, and friends. You need to think about a whole. It's a holistic approach, which you all are familiar with. Evaluate symptoms thoroughly, like I told you. Think about potential causes and remember to consider causes other than the underlying condition. The patient might be having a rectal cancer, but patient might vomiting might be due to not due to obstruction, might be due to UTI. So think about other causes. Consider the impact of the symptoms to patient's quality of life. And remember, lastly, effective communication is very, very essential. You need to speak to the family, speak to the patient in very simple terms. Don't use medical jargon. If you explain to them, reassure the patients, half of their symptoms, not more, half, more than half of their symptoms might get better. You just tell them, this is part of your illness. You need to accept some of your symptoms, and then actually they might accept some of the symptoms and they will feel less distressed by it. And even the families might not actually always keep on bugging you about the patient's symptoms. Okay. And have a treatment plan, management plan, and get the family, get the patient involved in that management plan so they feel part of it. Okay. So, and that then they will feel empowered and they feel that they actually symptoms are getting better.